Morning, everyone. I am Dr. Prachi Utekar, Associate Professor and HOD in the Department of Pediatrics in YMP Homoeopathic Medical College, Kharghar, Navi Mumbai. I am first of all, I am thankful to Dr. Bagal sir, Dean, Faculty of Homeopathy, MUHS, for giving me the opportunity to present my topic on this platform, and entire MUHS team for their assistance. I would also like to thank Dr. Page ma'am. She's the principal of our college and she's a constant support for us. So, dear students, today we are going to discuss a topic, important topic from the pediatric practice, that is pneumonia. Okay. So, pneumonia, now respiratory infections are the commonest conditions which are seen in the pediatric practice, and we need to. If you see in the clinical practice, one in three children are getting low respiratory tract infection in their first year of life, and if you see below 5 years, the 10 to 20% of the children are getting affected with pneumonia, and that is why it is very. There is a burden on this. This clinical condition is creating a burden on the on this children or the pediatric population, you can say. And nowadays, now we are experiencing the this pandemic also of novel coronavirus, that is COVID-19, and this is also again creating a burden, and it is the possibility is being made that in future course maybe the children may be the vulnerable population for this COVID also. So today our topic is community acquired pneumonias. It comprises of viral as well as the bacterial pneumonias, and of course the other different types of pneumonias we will be able to see. Now let me share. So today, the outline of my lecture will be, we'll see first of all what is the epidemiology, then the etiopathogenesis and pathology, the differential features of the lobar and the bronchopneumonia, the differential features of the viral and bacterial pneumonia, what are the different clinical presentations seen in children and infants, and what are the complications, diagnosis, and the management strategies, including the immunization and the preventive aspect, and the homeopathic management, that is assessment of its miasm, susceptibility, sensitivity, and what our the homeopathic stalwarts, or you can say the like Portland or a Woodford, what are their views on this and the remedies. So what is pneumonia? So pneumonia is basically defined as an inflammation of the lung parenchyma, that is alveolar and the distal airways. Now, since the children are having very smaller airways, that is why the respiratory infection, the incidence of the respiratory infections is very, very commonly seen. Because of the smaller airways, they get affected easily by the environmental factors. So if you see the epidemiology, pneumonia is even considered as a leading cause of death in under 5 in the developing countries, and India is a developing country having too much of crowding, and the socio-economic status is also low. So incidence is very, very much higher. If you see the different diseases in children, you can see in the diagram that is the children, mostly the respiratory and GI infections are predominantly seen. Along with this, the malaria, measles, eruptive fevers, and other infections are very much commonly seen in children. But in that, pneumonia comprises of 19%. And if you see the death rate also, so 15% of all deaths of children are under 5 years is because of the pneumonia. This is a recent data by WHO, and by UNICEF also is mentioned that a child dies of pneumonia every 39 seconds. So this is the magnitude of the problem of the clinical condition. And now again, this novel coronavirus is coming into picture, and which may cause a burden. So there is really need to pay attention to this problem. We should all need to know about what is pneumonia and what are its clinical features and how we can manage it. So pneumonia is basically the community acquired pneumonia. So it is broadly it has been classified as a community acquired and nosocomial. So community acquired means it is outside the hospital setup. That is environmental factors, the organisms. That is basically because of the pneumococci, streptococci, staphylococci. And nosocomial means it is hospital acquired. And usually the Klebsiella, Pseudomonas, and Staphylococcus aureus. These are the organisms responsible for the nosocomial of hospital acquired pneumonia. If we see the anatomical classification, the lobar, bronchopneumonia, and interstitial. These are the three major types according to the region there. I mean the pathological region involved. Now, if you see the etiology, there are various causes. Pneumonia can be caused by the viral, viruses, bacteria, or typical organisms like mycoplasma, fungi. There is aspiration pneumonia, kerosene pneumonia, or hypersensitivity pneumonia. But in children, if you see, mostly the viral and bacterial pneumonia percentage is 44 to 85%, and the pneumonias, mostly the viral pneumonias are predominantly seen in the younger age group, and the bacterial one is usually seen in the older age group, that is preschool children. So if you see the age-wise classification, less than 1 month, you can see in the table that is streptococcus. Usually streptococcal infection is one of the commonest cause for the respiratory distress in the newborn. And staphylococcal infection is also commonly seen in the first year of life. Staphylococcal skin infections, which are commonly seen in the pyodermas or impetigo, these are actually seen in the first year of life in children, babies, and they can spread the infection to the lungs also. So 1 to 3 months usually viruses. So after that, about 2 years, you can see that the viruses are the predominantly seen. So respiratory syncytial virus or RSV is the important virus which is causing pneumonia in children. Along with this, there is adenovirus, rhinovirus, influenza, and parainfluenza. These are the viruses. Influenza, the H1N1 variety. And bacteria, mostly the pneumococcal bacteria is one which is 90% more responsible for the lobar pneumonias in children. But along with this, as I said, streptococcus and mycoplasma and chlamydia is also responsible. Now the pathogenesis is based now how the pneumonia has been caused. So there are different ways like inhalation, aspiration, hematogen spray, or direct spray. So inhalation of the microbes which are present in the air, or the aspiration from the nasopharynx or oropharynx, mostly the children usually, and during the time of birth also there is aspiration pneumonia, there are chances of aspiration pneumonia. Hematogen is sprayed from the distant foci of infection, and direct spray from the as I told you that infectious direct spray from any injury to the lung, that from that infection can get caused and pneumonia can occur. Now there are certain factors affecting this defense mechanism, that is the host factors and the microbial factors. Now respiratory system is basically very much protected by this defense mechanism, that cilia, the mucus formation, which are actually protecting function, and the alveolar macrophages. These are also there, which are present in the lungs, and they are able to protect the respiratory system from the outside infection. But certain host factors like altered consciousness, which can occur in the epileptic child or a comatose patient. Depressed cough and glottic reflexes, which can be seen in certain neuromuscular conditions. These are responsible for the depressed host factors. Impaired mucociliary transport, impaired alveolar microphage function. This is due to mainly because of the recurrent viral infection in children, and the smoking. The passive smoking also is responsible for this. Endobronchial obstruction because of some foreign body of tumors is possible. Leukocyte dysfunction is mainly seen in the immunocompromised states of the children, like HIV or AIDS children. So these are the things which can, these factors can contribute to the infection. And microbial factors like pneumococcal capsule, which inhibits the phagocytosis, and the mycoplasma, which causes failure. So these are certain microbial factors which will actually cause the pneumonia in a child. And what are the risk factors in children basically? So low birth weight babies or preterm babies. These babies are most vulnerable or they are developing pneumonia. In preterm babies, the lungs are immature and low birth weight, malnutrition, all these factors can contribute. Certain vitamin deficiencies, lack of breastfeeding, the passive smoking, poor socio-economic status, large family size, overcrowding, and family history of bronchitis. So these are certain risk factors in children. Now, as I said, there are three main categories of classification: lobar, bronchopneumonia, and interstitial. Now, before going to each one, we'll discuss shortly about pathogenesis, how it is being developed. That is huge when the bacteria or the virus bacteria when takes entry into the alveolus, then the inflammatory process starts. So it is not one or two bacteria. When the bacteria are quite in number, multiple numbers, and then when they reach the larger amount, then the picture starts. I mean there is accumulation or the multiplication of the bacteria inside the alveolus, and the inflammatory mechanism sets in. That is the local production of the cytokines which is there. Alveolus has the IgE or the IgE and macrophages, alveolar macrophages which are there, and they are quite protective in the preventing the pneumonia or the inflammatory process. But these macrophages, again, they are deficient and body starts producing more and more number of macrophages or WBCs. And then when there is an aggregation of the inflammatory response inside the alveolus, there is a recruitment of the neutrophils, there is the release of cytokines, and everything will cause a inflammatory exudate inside the alveolus, or the accumulation of the fluid or a pus inside the alveolus, and this is hampering the air exchange, the oxygen exchange, and then that is why later on the symptoms will start. So this is basic pathology or pathogenesis we can say. Now, as I said, in lobar pneumonia, as the name suggests, it involves a part of the lobe or whole lobe or the two lobes. So affection of the lobe lobes is commonly seen. Now, what is there in lobar pneumonia is basically having a classical 4 stages. That is, stage of congestion is the first stage, which is the initial phase, and it is lasting for 1 or 2 days. So if you see the microscopic picture, usually the lobe is enlarged, congestion, all the signs of inflammation come into picture. So the microscopically lobe will be enlarged and congested, and microscopically if we see that there will be a dilatation and congestion of the capillaries in the alveolar wall, and edema fluid which appears in the air spaces. Few neutrophils will be there, with numerous bacteria will be there. So this is first stage, that is stage of congestion. Second stage is red hepatization. Since the name suggests, hepatization means liver-like consistency. So in this stage, the lungs become start becoming a solidified, and the liver-like consistency it gains. So microscopically, if we see, the lobe is red, firm, consolidated, and cut surface is airless, dry, granular. Microscopically, you can see appearance of a strands of fibrin. So fibrin strands appear at this stage, and marked cellular exudates and neutrophils and red cells are seen. And neutrophils with ingested bacteria is also seen, and alveolar septa are less prominent. The next stage is gray hepatization, which is also called as a late consolidation, and it starts around 4 to 8 days. So microscopic changes are the lobe is firm and heavy, and cut surface is granular and gray in color, and fibrinous pleurisy is seen. And here the macrophages begin to appear in the tissues, and the dense fibrin strands and few neutrophils are seen, and the number of bacteria is becoming less. And last is the resolution state, and which sets in 1 to 3 weeks. So this here solid fibrinous constituent is liquefied by the enzymatic action, and here the softening begins from the center of the lung and it goes towards the periphery. So here the macrophages are predominant cells seen in the lungs, and granular and fragmented strands of fibrin are seen, and neutrophils degenerate and bacteria are getting digested. So these are the four main stages of the lobar pneumonia. Now, the bronchopneumonia is also called as a lobular pneumonia, that is infection of the terminal bronchioles or patchy consolidation. So, characteristic of bronchopneumonia is it has a patchy consolidation. So, if we see here the what are the changes at the microscopic level, the bilateral involvement is majorly seen in the bronchopneumonia, and the lower lobes are mostly involved, anatomically. And here the suppurative exudate consisting of neutrophils in the peribronchial alveoli, and thickening of the alveolar septa is seen, and edema fluid is also visible in the alveoli. This is again the patchy intra-alveolar neutrophilic exudate, which is more prominently in the periphery. This is installed appearance of the bronchopneumonia, edema fluid and the inflammatory cells. Interstitial pneumonia is also called as a viral pneumonia, as a third variety. Now, as the name suggests, interstitial pneumonia, it is basically the pathology is seen in the interstitium, in between the alveoli, the interstitium of the lung. So lungs are heavy and congested, and here we are characteristic finding is patchy inflammatory changes in the interstitial tissue without any alveolar exudate. In the lobar pneumonia, in the previous pneumonia we have seen that is alveolar are filled with the pus and the fluid basically. So, and that is alveolar exudate. But here it is absent, and it is since the infection is limited to the interstitial tissue. Then here, in microscopically, if you see there is congestion and edema of the alveolar walls, necrosis of the bronchial walls can be seen, or necrotizing bronchiolitis, necrosis in the bronchial epithelium. Epithelial cells proliferate to form the multinucleate giant cells, and in severe cases, sometimes the alveoli may show the exudate, but it is very less likely that interstitial variety will not show this. Now, what are the differences between broncho and the lobar pneumonia? So, when the process is restricted to the alveoli, contiguous to the bronchi, it is called as bronchopneumonia, and when the entire lobe, or the part of the lobe is involved, it is called lobar pneumonia. So here, usually on X-ray also you can see the patchy consolidation, and here the entire lobe you can see the homogeneous opacity in the lobar pneumonia. And most of the time it is seen that bronchiolitis. Now, bronchiolitis is very much common in children or infant basically. So, less than 1 year of age, usually the incidence of bronchiolitis is more because children have a smaller airways, and the inflammation of recurrent viruses can cause recurrent infection. Because of the recurrent infection, these bronchioles get affected, and these bronchiolitis again, the infection can extend to the larger bronchitis can prepare. And here the lobar pneumonia, the direct injury to the lobe of the lung is happening. Common age is basically infancy for the bronchopneumonias and old age. So it is seen at the extremes of ages, and in lobar pneumonia, usually the older children are getting affected. In bronchopneumonia, as I said, the multiple organisms are responsible: Staphylococcus, Streptococcus, Pneumococci. Lobar pneumonia, predominantly pneumococci are responsible for development of the lobar pneumonia. Here is a good picture of broncho and lobar pneumonia. Here you can make out that it is patchy consolidation. Here the whole lobe is getting involved. So X-ray film also, here you can see. This is a bronchopneumonia which is having a patchy opacities you can see in the lung tissue, and your entire lobe is having, the half of the lobe is having the homogeneous opacity. Interstitial variety, again there is a interstitial tissues, they are getting, there is a streaky white appearance at the periphery of the lung. Now, pathology-wise, as I told you, there is a patchy consolidation, and here the multiple lobes can get affected. And basically, the affection of the lower lobes is common because of the gravitation. And here, the lobar pneumonia, the fibrino-suppurative consolidation is seen. The classical 4 stages, as I told you, is observed in the lobar pneumonia, and in bronchopneumonia, usually the small regions like 3 to 4 centimeter in diameter, these can be seen pathologically. and it has a neutrophil-rich exhibit. Now, coming to the difference between the viral and bacterial pneumonias. Now, clinically, we actually cannot much differentiate, but there are few differences we need to understand. That is, viral pneumonias are common in infancy and in children, and bacterial pneumonias are commonly seen in the older children, age group wise, and is preceded. Now, most of the time, viral pneumonias are preceded by several days of respiratory infections like rhinitis, cough, cold. But here, bacterial infection or the bacterial pneumonia, there is a mild URTI with some skin lesion which is there, and then the pneumonia sets in. So there is a sudden onset or abrupt onset of the fever and cough and respiratory distress is commonly seen in the bacterial variety. Here, viral pneumonias have compared to the bacterial one have low temperature. Here, low temperature means compared to the bacterial pneumonia, less temperature is being noticed, and bacterial pneumonia means they have a high grade fever and chills. Investigations in this is WBC count is usually normal in viral variety. Also, mild increase may be seen, and WBC count is usually less than 20,000, and WBC count is quite raised in the bacterial variety. And predominantly cells, lymphocytes are seen in viral one, and in bacterial one, the polymorphs are seen. ESR and CRP, C-reactive protein, is normal or mildly increased in viral one, and in bacterial variety, it is increased. And chest X-ray is quite evident that you can get a consolidation in bacterial variety, and in viral variety, you can get hyperinflation with bilateral interstitial infiltration. So the hyperinflation of the chest, you can see the flat diaphragm, you can see, and interstitial, the periphery of the lung, you can see the opacity. Prognosis is good that way in viral variety, and in bacterial one, usually there are complications like empyema or bronchiectasis. This is again the age group wise classification, which pathogenic agent is predominantly seen. So, pneumococcal is older children, staphylococcal is infancy, streptococcal in 3 to 5 years, and Haemophilus influenza usually in 3 months to 3 years. So, already I think explained in pathology. Some special features of different types of pneumonias we need to understand that pneumococcal pneumonia has a lobar inflammation and is seen in older children as a whole. Staphylococcal is seen in infancy and usually after measles. It is one of the complications of the measles. So measly pneumonia is being termed. Influenza or malnutrition is another cause. And nematocils are seen on the chest X-ray. That means the cystic cavity you can make out on the X-ray film. In streptococcal, a variety is usually post measles, chickenpox, and influenza and whooping cough we can see. And streptococcal infection is one of the important cause of respiratory distress in the newborn. Haemophilus influenza infection, it mimics acute bronchiolitis. So usually it is seen in the less than 1 month of less than 1 year of age. Gram-negative bacteria infection is usually seen in less than 1 year, and malnutrition and poor immune status of the child is also another factor. Viruses, we have seen the respiratory syncytial virus is very important, less than 2 years, and it has an interstitial pathology. Some parasites like you can see, or the larvae of nematodes, like ascaris, hookworms, tonsilloids, these have again during their life cycle can affect the lungs, and that is one syndrome. It's called as low flux syndrome. And pneumocystis carinii infection is commonly seen in HIV children, HIV positive children. These are certain things which are important. Neonatal pneumonias usually can be categorized into congenital, intrapartum, and acquired. So congenital, it is mainly the infection getting transferred from the mother to the fetus, that is transplacental transmission. Intrapartum, most of the time during delivery and from the birth canal, the infection can get transferred to the child, and acquired because of the microorganisms or infectious causes. It is early onset and late onset pneumonias are also there. There is early onset in first 4 to 6 hours of birth and late onset after 24 hours of birth. And there is again aspiration pneumonia, that is meconium aspiration, usually is seen in during the deliveries. Now, 15 to 20% of the deliveries are with the are having, the labors are having the meconium stained liquor, and 5% of the infants are affecting with this meconium aspiration pneumonia, and most of the children require a mechanical ventilation or NICU treatment in the NICU setup because of this. So usually this meconium aspiration seen in the post-term or the term babies. Primary atypical pneumonia is another variety. It is responsible organism is Microbial pneumonia. It is seen in the school children more than 4 years. And here you can say that there is absence of the alveolar exudates, and interstitial infiltration is seen, and necrosis and ulceration is seen. So here, in atypical pneumonia, usually the fever is not much present. So there is another variety of atypical pneumonia, mainly caused by the chlamydia trachomatis, which is responsible for the conjunctivitis in babies. And that in that particular pneumonia, the child is having cough, cold, all symptoms, but fever is absent. And that is very characteristic, and that is why it is called as atypical pneumonia. Then there is a nosocomial hospital-acquired pneumonia, which is occurring at least 48 hours after hospital admission, and usually these organisms are responsible: Staphylococcus, E. coli, and Klebsiella. Incidence, if we see, there is a 5 to 10 cases per 1,000 hospital discharges, and then there is another variety, there is ventilator-associated pneumonia. Usually, the babies who are on in the NICU mechanical ventilation or the ventilatory system, they can have this, and usually it occurs after 48 hours of the ventilation. So these are the different types and pneumonias. Now coming to the clinical features, what are the different features in infant and children? Now in infants, usually there is a symptoms of mild URTI with fretfulness, stuffy nose, appetite, placebo onset. It is quite common in children also, but recurrent viral infection is commonly seen, as I told you, in the younger children or the infant. And abrupt onset of fever is there, restlessness, apprehension, air hunger, cyanosis, respiratory distress. There is a flaring of LNSI and retraction of the chest muscles seen in the infant or the young babies. And in children, if you see, there is a shaking chill with a fever. There is a drowsiness, restlessness, and anxiety. Dry hacking cough. Cough is predominantly seen in the older children. Occasionally delirium and circumvented cyanosis if it goes to severe stage. And pain on the affected side. Actually, usually the child turns on the one side and sits with the knees drawn up because there is a pain on the affected side. Tachycardia, tachypnea definitely is observed in the infant. So lethargic. Usually on examination, we see the infant is lethargic and it's a toxic mood readily seen. I mean, the severity is more seen in the infancy, and in older respiratory distress, moaning is there. Subcostal dissecations, intercostal dissecations are evident in infancy. There is a dullness in the later stage, and the diminished breath sounds can be seen. And here, the child, you see the older child. So usually he's tilting on the affected side with the knees drawn up. Sometimes there is a, because of to help the respiration, he you may notice that there is a rigidity in the neck, and sometimes we get confused with the neck rigidity with the meningitis. So we need to see whether it is the actual pneumonia or it is a meningitis also. So these are the things you can see here. The LNSI, flaring of the LNSI because of the child is not able to take proper decision. So that is why this is a sign. Here you can see the intercostal retractions, and abdomen may distend while the lower sternum retracts and causing seesaw effect. So these are the signs which can. Now there are some videos which are actually of the respiratory sound. Right. 1 second. 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 1 this is a grunting of a child. Can you make out? Everyone's, I mean, is it audible? Is it audible? Okay. This is the grunting of the child. Here you can see the retractions. Here you can see the retractions. You can see the ribs are getting inside and outside. And see the abdominal movements. This is called as subcostal and intercostal retractions are there. But this movement, if it is evident in a child, then it is as a sign of a severity. Then there are two sounds, which abnormal sounds, which can be heard during a pneumonia. That is crackles. So crackles. So this is not audible, but there is crackles. When the crackles are there, actually, there is when the air passes through the fluid, and there is a fluid collection in the alveoli, and the air passes. Then there is a crackling sound is there, and these when there is a air which is going through the bronchi, the narrow space basically. So these is audible. So these are important signs which we should look for in a child with a pneumonia. So tachypnea is the most sensitive and specific sign of the pneumonia, and WHO has given a definition of tachypnea as age-wise. That is, if a baby is less than 2 months, then and if the respiratory rate is more than 60, it is considered as tachypnea. In 2 to 12 months of age, more than 50 is the respiratory rate is considered as tachypnea. In 12 to 5 years, 12 months to 5 years, it is more than 40, and more than 5 years, it is more than 20. And severity, if it is there, then less than 2 months, the respiratory rate makes it more than 70. And here, about 1 year to 5 years, it is more than 50. So there is pneumonia severity assessment is also there, which categorize it in mild and severe variety, and in infant and older children, the temperature is less than 38.5 degrees Celsius, and RR is less than 50. Mild recession and taking full fills. In severe variety, the temperature is more than that is 38.5, and respiratory rate increases more than 70 breaths per minute. And there is a nasal flaring, cyanosis, intermittent apnea, grunting respirations, and baby is not feeding well. In older children, the temperature and the respiratory rate is almost the same variety, but mild breathlessness is seen and no vomiting is experienced. But in severe variety, temperature is more than 38.5 degrees Celsius and respiratory rate is more than 50 breaths per minute. Severe difficulty in breathing, nasal flaring, grunting respiration, cyanosis, and signs of dehydration is evident in the older children. So in infants, when you actually examine, we need to, if a child is in the infancy, below 1 year, we need to examine the anterior continents. We need to see the signs of dehydration. They are there, and if they are there, then we need to refer the patient and hospitalize. So WHO classification of pneumonia has been given that no pneumonia and pneumonia is severe pneumonia, 3 categories. Initially, the differentiation was this is the latest one. The old one was fast breathing and chest inflowing were coming in the severe pneumonia. Now they have put it in the pneumonia. So if a child is having simple cold and cough, it is no pneumonia. If a child is having fast breathing and chest inflowing, along with this, it is pneumonia. And if the child is having general danger signs, like I just told you, that there is the breathlessness, dyspnea, or the signs of dehydration. So these severe respiratory distress, central cyanosis, these are considered as a severe pneumonia. Now coming to the complications, usually you can see that pleural effusion is quite a commonest complication of the pneumonia. Then the empyema, that is supported bacterial infection, pus formation is there. Lung abscess, bronchiectasis, wherein there is a dilatation of the bronchioles and accumulation of the fluid. Metastatic infection, that is purulent pericarditis or bacterial endocarditis, purulent arthritis, and otitis media. So the infection from the lungs can travel to the heart and the joints and the ear also. So coming to the diagnosis, in children, basically the CBC is quite helpful. I mean, we can make out the WBC count is raised or no, and see the observation of the cell count, eosinophilia is there. It's mostly seen in the allergic conditions. But CBC and ESR is a common routine practice. Blood culture is not much advisable, but hospitalized children we can advise blood culture for them. Chest X-ray to confirm it. Then the clinical findings, if we are getting the air and chest findings, if we are getting the reduced air and the clinical signs are quite evident, then we can confirm our diagnosis with the chest X-ray. But usually, routine basis, it is not advised. Sputum examination also is actually, since the babies are not able to produce the sputum examination usually is advised in adult, but in older children, we can. Bronchoscopy, thoracoscopy, lung biopsy, and pleural aspiration. These are some invasive procedures which are rarely needed in the mild moderate variety, but in severe variety, definitely if there is a pleural effusion, then thoracocentesis and the biopsy, this can be done. Now, management, there is a generally we can mild and moderate variety, we can manage it at the OPD level. So, usually general management includes infusion of the antibiotics in the bacterial pneumonias like amoxicillin, cephalosporin, ceftriaxone. These are certain drugs of choice in the modern medicine. And inpatient management, if during the severe variety, it is needed, and antibiotic treatment is continued for 10 days with the supportive management like antipyretics, analgesics, oxygen, that is mask, or nasal cannula. Along with this, we definitely need to keep watch on the hydration of the child, the nutrition, the diet, and the chest physiotherapy is required to be given. Now, the preventive aspects, there is definitely nowadays we are experiencing and we are actually following also, that is respiratory hygiene, frequent hand washing, and the promotion of breastfeeding, specifically in the smaller babies, is very, very important to prevent any viral or bacterial infection. Proper diet and nutrition, that is supplementation is needed, supplementation of vitamin C and zinc and vitamin D is needed. Immunization, we see in pneumonia, mostly it has been said that influenza vaccines has been given beyond the 6 months of age, and this is a routine practice. Actually, it should be given. The pediatrician should give. But immunization, whatever mentioned in the immunization schedule, there are two vaccines. That is pneumococcal conjugate vaccine and pneumococcal polysaccharide vaccine. So PCV13 and PPSV23. So these are the PCV13 is it is very effective for all these 14 types of pneumonia, this community acquired pneumonias, and all the children below 2 years should receive this vaccine, that is at 2 months, 4 months, 6 months, 12 months, and booster dose is given at the 15 months. And pneumococcal polysaccharide vaccine usually is rarely given beyond 2 years, but it is usually recommended for the adult population 65 years or older. But apart from this, influenza vaccine can be given. Now, the homeopathic management. Now, we have seen the pathology, we have seen the clinical course, what are the different features. Now, how homeopathically we can manage? Now, for a homeopath, we need to understand the evolution of the symptoms. That is, what is the causative factor, the modalities, concomitants, like our regular case taking pattern. That is, we need to inquire about the thirst, appetite, sleep, and ability to suck in infants and hormones, and past illness and family illness. So, this is regarding the history. Second is physical examination. The child should be thoroughly examined and kept in a comfortable position. So examination is a bit difficult task in case of infants. Older children at least can cooperate, but in case of infants, it is a bit difficult. So we have to make child comfortable in the mother's lap or arms and should be distracted. Then what to look for in a child or a baby, that is alien enzyme. Is there any flaring of the alien enzyme? Is there any use of accessory muscles of respirations? That's what I showed you, that there is a subcostal fixation, so accessory muscles are getting used. Is there a moaning or grunting in a child? Is there a cyanosis, a peripheral or a central? And definitely the temperature, respiratory rate we have to observe. In chest examination, the breath sounds is important. Now in pneumonia, usually we have to see here the diagram has been given where exactly you should actually auscultate. So for air, entry, you have to examine at the apices of the lungs, then at the middle region also, and the dots are orange dots which are shown. That is, it is being for the mostly for the hearing of the this wheezing sound, basically the bronchial breathing, and the yellow dots which are being shown. Actually, it is for the hearing the crepitations or the crackles. So we have to examine for the air entry and the crackles and the wheezing sound if they are there. We have seen that usually the viral pneumonias leads to this bronchial breathing more often, and when there is a effusion sets in, then there is a crackles, and when there is a consolidation of the lobar pneumonia, usually the air entry is getting hampered. So we have to this chest auscultation is a bit difficult in infants because they have hyper resonant chest, and they are crying and they are doing some sounds, so it's a bit difficult. So we have to make the child calm also. For abdominally, we have to see whether there is organomegaly. So liver and spleen in infants till 2 years of age or 1.5 years of age, it is palpable, that is physiological one. And if there is a hyperinflated chest, the liver and spleen definitely is coming down, so it can be palpable. Then we have to observe the skin turgor, that is signs of a dehydration if they are there. In infants, we have to see the anterior fontanelle, their depressed, what is the status. And in children, the neck rigidity, the toxicity is present. Because neck rigidity, I told you that might be because of the increased effort of the respiration, or it may be because of the complication as the meningitis. Investigations, so definitely we need to send along with this after the history and physical examination. Management aspect, we covered two things, that is whether we can manage it at home or whether the child is required to be hospitalized. So at home, the child is active, playful, and mildly dull or weak, still we can manage at home. And the respiratory rate is below 60 and no respiratory distress. And when hospitalization is indicated when there are high fever spikes, chills, and the respiratory rate is above 60 and respiratory distress is present. Definitely, respiratory distress should be according to the age, the respiratory rate. Now, coming to the homeopathic management, before that, we need to understand the susceptibility, miasm, and sensitivity in the child. Then only we can actually understand the exact understand the disease, and we can select the proper potency and the repetition. So this is one tool. Actually, this is called as a structure form function tool. So it is not like we have to follow this, but it is, if you follow this, it's our clinical understanding, clinical pathological correlation is understood in a better way. So it's not that you have to make a triangle, you can just make 3 columns and you write down what structure is getting affected, what form is getting displayed, and what function is getting affected, being abnormal, become abnormal. So if we correlate this, then we can understand the pathology in a proper way. So this tool actually, now here you can see this is structure, form, and function. So in structure, the upper side of the triangle, that is what structure, that is lung parenchyma, alveolar, bronchioles, these are getting affected. What is the form on the left hand side? That is, what is the function on the right hand side? That is failure of the defense mechanism, that is decreased mucociliary clearance and inhibition of the polymorphonuclear cells, increased cough reflex, decreased lung compliance, all these are coming under the function. So which function is getting hampered? And what is it is showing, that is signs and symptoms is seen in the form, that is fever, shaking, chills, dyspnea, cyanosis, all this can be seen. Now this SFF model or the tool, you can say, it will help correlate clinico-pathologically. So here we can see the symptoms and here we can see the function and what structure is affected. So here it will help to understand in which stage and in which state the child is there, and then we can after select it is help that whether the characteristic things are present in this, characteristic symptoms are present or only common symptoms are present. So it will help us to actually select simillimum also, that is it will help us to form the which potencies to be selected according to the susceptibility. Because from here, if the characteristic form is present, then definitely susceptibility is more higher. If the mental symptoms are also there along with this tissue susceptibility, then the sensitivity is higher. So that is why it will help us in the selecting the potency also. Now susceptibility has two aspects, that is qualitative and quantitative. That is, if you see in the quantitative aspect, as you know, that susceptibility might be low and might be high, or it might be moderate also. So, and the myasm, usually it is a qualitative aspect of susceptibility, you can say, that the coming in soda, psychosis, tuberculosis, and syphilis. Now, we see the pneumonia per se. So, usually there are more of characteristic symptoms which are available and the pathology is reversible. So in that case, you usually have a moderate to high susceptibility. And if a child is very toxic, lethargic, very respiratory distress is there, compromised state, if there is irreversible pathology, or there are complications which have set in after pneumonia, like empyema, lung abscess. So in that case, the susceptibility would be low. So from this susceptibility, we can decide which potency or which dose is to be needed. There is a qualitative aspect, that is, as I told you, that usually myasm is getting covered in this variety. That is, pneumonia generally presents a tubercular trait, myasm wise, as a disease wise. But because of the rapid involvement of the chest, erraticity of the symptoms, and low reactivity leading to the exhaustion and debility. But it's not like that pneumonia, a child in a pneumonia can have a psychotic variety also and can go into the syphilis also, depending upon the what pathology or what clinical expressions he's going. So if there is a gradual onset and the symptoms are not very much evident, so it can go in the psychotic variety, and when there is a complications and sensing there is a destruction of the tissue, then usually it is going towards the syphilis. This is about the susceptibility and the myasm and the sensitivity. So what is sensitivity? It is basically the living organism would react to the environmental stimuli. Okay, and sensitivity is usually assessed at the level of the mind and nerves. So when we call high sensitivity, when a child is very much irritable, crying, very much restless, anxious. So if this is the presentation, then usually the sensitivity is high. And when the child is very much drowsy state or toxic mood is there, then usually sensitivity is low. So there is no reaction actually to the environmental external influences in a low sensitivity. So treatment as is there according to this, that is, we can give a remedy according to the form, that is, acute remedy can be selected, or the constitutional remedy can be given. Sometimes the pneumonia and pneumonia, it is mentioned in the borderline pneumonia also, that if the case is not progressing further, then the intercurrent remedy can be used. So that can be given if this case coming to the standstill. Potency and repetition depends on the susceptibility. Now there is a prevalence view there. He has given a different drugs, the medicines actually remedies according to the stage of the pneumonia. So he has divided the pneumonia in 4 different stages, like incipient stage or the initial stage, frankly developed, complicated, and late. Now, in incipient stage, usually the remedies which are coming in the initial stage of the inflammation are the aconite, belladonna, ferrum. These are the epicac also can come in this. Frankly developed pneumonia, Gramia, phosphorus, and chelidone, and in complicated one, usually the bacteria, lysis, heparsal. In late pneumonias, the Kalika, glycol, sulfur is being there. Now, he has written that in homeopathic prescribing, our endeavor is to find a drug which will cover not only the actual pathological picture, but also the reaction of the individual patient to that disease. That is called as a susceptibility. Now, what he has observed and he has portrayed that there can be cure by lysis or a crisis. So lysis means there is a repetition till end, that is we need to select memory and give it a potency till the end. I mean, till the that disease is getting cured, and we require more than one drug to complete the cure. And in crisis, when here we need to select a remedy and a potency as such that we need to abort the disease. There is cutting down the course, and in this variety, the complications are less observed. And here, the repetition till 6 hours after the temperature touches to the normal, and 2 hourly or 6 hourly is the repetition. Now, he has given certain guidelines, and we can say the Borland's view on the physiology in this respect. That is, he has said that if you want to avoid the disease, use high potency and infrequent repetitions. If using low potency, needs frequent repetitions. And in frankly developed pneumonia, 6 doses of medicine, 2 hourly and then 4 hourly. So 10 minutes is beneficial. What is observation? In complicated pneumonia, 1 m potency is observed beneficial compared to the 10 m, and it produces less disturbance yet definite reaction. And in late pneumonias, use of 10 millisimole potency, 2 hourly repetition observed as a beneficial. So this is the Borland's view. So Pulford is also again given some mention that if you select a simillimum, then we can actually cut short any disease. So usually of repetition. So it is actually opposite to the Borland's view. Pulford has treated almost 242 cases of pneumonia of all types and degrees of severity. And he has stated that death rate under homeopathic simillimum should at no time exceed 5%, higher rates to rather regulate. So there are 2 ways. That is one thing, that low potency, use of low potency and repetition, frequent repetition, or the high potency you can give at one time. But definitely we need to clinically correlate also when we are selecting the potency or dose repetition. Now there are homeopathic remedies which are enlisted here. That is ferrum, which is usually seen in the starting phase or the initial phase of the pneumonia. That is aconite is also one of the drugs which is coming in this category, and it develops little longer. I mean, the pneumonia develops little longer compared to the aconite. Localized flush is seen in the malar region, and the child is indisposed to talk, and incessant tormenting cough is seen here. Right-sided chest affection is predominantly seen, and aggravation is 4 to 6 p.m. In primary variety, usually you get a gradual evolution of the symptoms, and mainly the stitching pain in the chest. Pain in the chest is quite evident, and aggravation by movement or lying, or better by lying on the painful side. Here, the child will have a dry cough and headache, and sometimes delirium about the business like stool, or it may be evident. In focus cacti, there is a stringy focus discharges which are difficult to expectorate. This is a presentation, and child coughs still vomits a large quantity of the mucus, and usually aggravation is after midnight and the drinking milk. Antum tart is a remedy which is coming a little later in the when the child is becoming drowsy or a toxic also, or a rapid travel from when there is a rapid travel from the upper respiratory tract to the chest. So here you can get excessive secretions, the pores rattling in the chest, drowsiness is there, toxicity as if the child is sinking, moaning, crankiness, and hoarseness is quite evident. So here carbo, which also another remedy which is coming close. So there are various remedies which are there, but in which stage of pneumonia we can apply these remedies? The Borland has explained wonderfully his Woodlands pneumonia, so that we can get a help from it. Now, I would just like to share that is with one case just to understand how we can make the assessment of the susceptibility and sensitivity to a case. There is a 1.5-year-old male child, and he started with the coraza 3 days back, and he had a fever at night, and after the exposure to cold, he developed the fever. And third day, there was a cough, and which was irritating and rattling and continuous with a high-grade fever, and cough, which was mainly aggravated when lying down and at night, and fever also was coming at night. There was a crankiness, dullness, child was very irritable and decided to be carried. And thirst was decreased. There was redness of face and heat of the partial head. So there was history of coraza and cough on and off since 3 months and better by nebulization and allopathy, and constipation was there on and off, stool dry hard has to strain, and which was better by allopathy. So these are certain investigations, and on examination there was a air entry was a little reduced on the right lower low, and bronchial breaks are seen in the right mid and right lower zone, and diagnosis is right lower pneumonia. There was a consolidation seen in the right lower lobe. So here, just to make you understand that how we can plot this, that is, there is a structure which is getting affected is lung, that is right lobe parenchyma. The function which is hampered is this, that is increased hyperventilation is there, increased cough reflex is there, and the form which is there, that is cough, which is rattling and high grade fever. So there is a progress. This is a this is the first, second, and third day. This is a time axis. And first day he developed coraza, and later on there is a development of the cough, and there is a development of the consolidation, or the starting of the haziness and consolidation. So inflammation, congestion, and red hepatization. So from this we can actually make out how much rapid is the course, or whether it is slow, whether it is with gradual, or it is more rapid. And we can comment upon the margin from this. So totality is been taken, and here the SINA is drug has been prescribed to this baby. That is elements from exposure to cold, irritability during fever, dullness during fever, thirstlessness and fever at night and lying down, and what is also the night aggravation is there. So here, when after giving SINA, there usually the first registration we registered, first thing was registered at the mental level, that is crankiness was reduced almost 3. Dullness was reduced, and then the cough and fever also got reduced. So evolution of the disease, if we say, that is the onset is quite sudden, there is a progress is moderate, and pathology is structural reversible. And at the mind level, we can see the crankiness in the child, dullness in the child, there was a red face. So sensitivity is coming to the higher side, and evolution of disease, susceptibility, tissue susceptibility, we see it is towards the moderate side we can come in. So, and miasmatic mostly going in favor of tubercular because of the structural reversibility and the structural involvement and the rapid progress. So this is understanding of the case according to this tool. But definitely we need to select dose and the potency according to the susceptibility of the child. We need to see the what are the different presentations at the mental level, and definitely we need to clinically also need to correlate, and then we can finalize the remedy and we can manage the case. So ultimately we need to treat the child in the disease and not the disease. So this is the overall management aspect of the pneumonia in children. So thank you very much for patient listening, and thank you the Majors team for their assistance. And here I'm concluding the lecture. If any doubts, you can call me, or my number is displayed over there. Thank you so much.